Coming up on this episode of Healthy Longevity.
There's nothing like testosterone for a woman's libido.
Yeah, we use it as well.
The secondary benefit was what we were looking for, which was better orgasms.
We have the same issue with some men who, when they come in, say, oh, the sex life is fine. And then when we stimulate testosterone, 2-3 weeks later, they call up and, Doc, can you wind it back a little?
I put PRP everywhere. It's in my face, it's in my breast. These procedures are remarkable.
Great sex strengthens relationships, builds self-esteem, and it's terrific for the entire system. And for those reasons and many, many more, a fulfilling sex life is a vital part of achieving healthy longevity. But it's actually estimated that more than half of all women deal with intimacy issues and sexual dysfunction in their daily lives. Fortunately, there are effective therapies for common sexual problems like low libido or painful intercourse, also known as dyspareunia. Today, my guest on Healthy Longevity has helped thousands of women improve not only their sex life, but their health as well. Dr. Carolyn DeLucia is a board-certified OBGYN and founder of the Secret Orchid in Hillsborough, New Jersey. She's a leader in the field of non-invasive sexual wellness, treatments, and more. I think you'll be just as fascinated as I am by what she has to share. And I'd like to start with a little bit of an intro from Dr. DeLucia.
Thank you so much for having me today. It's wonderful to be here. I am an OBGYN, practiced regular hard labors and normal gynecology for many years. And then I stopped doing obstetrics to be home with my kids a little bit more. I have 2 grown women now, and that was very important to me. So I stopped doing obstetrics and started doing GYN only, and have evolved my practice into being able to help women remain active and willing participants in their intimate lives. And that does involve, believe it or not, keeping their partner active too.
So you see both men and women.
I do
Fantastic.
Because I treat partners. I really want both partners to be willing and active. I don't want to get my women all kinds of crazy and then they have nowhere to.
So we have the same in reverse, where we really help men get jump started, and then they'll come in and say, "My wife has to see you now." So I fully understand that notion of partnering, and also from our point of view, we're partnering them as well. So that is important.
Exactly.
So I'd like to start with that conversations around fertility and female pleasure and menopause are seemingly becoming more open, certainly more than 2-3 decades ago when I started with women's health, and it was all hush-hush. I was actually told by my dean at Yale that I was asking too many intimate questions, and I looked at him like that was strange because the women loved it and started bringing their husbands by. So that was fun for me.
Yes.
Do you agree, or do you think that the vagina and menopause are sort of still a bit off limits and a bit nerve-wracking for women and men to bring up in conversations with their physicians?
I still think that it's way too much taboo, but we've made huge strides. Finally, women are willing to talk about their issues. Social media has helped. I'm not a huge fan, but it has helped bring some of these topics to the forefront. The only issue there, with, as you and I both know, is that there's a lot of misinformation. So it does open up the conversation, but as we know, we have to tailor it and individualize that information to our client.
Exactly, and it's misleading in some ways because you can start off thinking you're going to get good advice, but it isn't really necessarily the advice you need in particular. So I couldn't agree more. I think social media is a big leveler in terms of democratizing, but it needs to come from experts, not from people who think they know or what worked for them, and they're implying that it'll work for everybody. Agree?
Yes.
So you've been in OBGYN a long time.
Mm-hmm.
And when did you open your private practice, the Secret Orchid? And how did it evolve to sexual health, aesthetics, and just overall wellness?
I started a med spa doing Botox in 2002. It was in its infancy at that time.
Yeah.
And laser hair reduction, and my med spa evolved. So when the very first laser came to town that was for vaginal use, they came to me because I was an OBGYN who actually understood laser physics. So I was blessed with this strapping young representative coming into my office.
They always look like
as
that.
they always look off the pages of
Right.
GQ.
Exactly.
And he said, I have a laser that rejuvenates the vagina. And I said, get out of my office, you filthy pig. And he's stumbling onto the sidewalk, literally. And he goes, oh, please listen to me. It may help with urinary incontinence. And I went, bing,
Yeah.
What did you just say? A laser that might do what? And he said, we think it helps with urinary incontinence.
Where we can't do much about that, right?
Without surgery, without slings, without mesh, women.
Much of it doesn't work.
And right, and then there's complications,
Exactly.
erosions, horrible things, painful intercourse afterwards. We're destroying the G spot. It's gone forever once women have one of those procedures. It's tragic. So a third of women have urinary incontinence, and that's those who admit it. And 45% of those women won't be intimate.
Yeah, because they're
Fear of leakage.
You can't do jumping jacks. You can't go on long car trips.
Right.
It's very hard.
It's
all of that.
very difficult. So to have something that
you
could
pulled
do
him
that.
back off the
So I
sidewalk.
pulled him back off the street, and I've never looked back.
So who's your typical patient, and what kind of concerns do they bring to the table? I'd love to hear about women and men, because
Yes.
you treat partners.
I do. I still have a gynecological practice, but when I see my patient, now it has truly evolved into those going through perimenopause, menopause, and having, or at any age, having hormonal difficulties, something that the average gynecologist doesn't handle. The difficult cases. So my visits are long, arduous, and complicated, as are yours, with more of a longevity approach than just taking care of one problem. I take care of the full health picture and attempt to improve their longevity.
So can you describe a particular case, a real case even?
Yes, this is one of my favorite cases. A 53-year-old woman who seemingly overnight, she says, she was having intercourse, and she had just been about a year without a menses, so this was official menopause at that point. But she was having intercourse, and it felt like a hairbrush instead of male anatomy, agonizingly painful. And also, she realized that reaching pleasure and orgasm was very difficult. She describes it like rubbing her forehead. There was no sensation.
Sounds like fun.
Whatsoever. So if it's not fun and it's
Right.
painful, why bother? Hot flashes kept her up all night. This is an older case, so she wore a Fitbit, and at that point it was telling her she was sleeping 3 hours a night.
Yeah.
So she had all the signs and symptoms, mood swings, and in perimenopause, what a lot of women come in at talking about are typically terrible mood swings when they're in estrogen dominance, as we refer to it, is when their ovaries are failing but still spewing out estrogen, and they have pendulum swings of emotion.
Exactly. Their estrogens can go as high as ovulatory 200, 300, and they have no
Yes.
progesterone. They can stay in that state for a long time.
Yes.
Which is actually not safe either, because if they have unopposed estrogen for 3 months or longer, cancer's at risk, endometrial cancer.
Indeed.
Yeah.
So I would love for more women to be aware that they're not going crazy, because so many women think, I don't know what's going on with me.
Right.
And my husband says, who are you and what did you do with my wife, right?
Right.
And it's really difficult.
It is.
So that's pretty much my typical patient, and we have to help them out. And there's many approaches. One is taking a look at all of their hormones, their cardiovascular health, all of their parameters, their vitamins, just everything, as we well know. And then going to see what can be done non-hormonally for the vaginal symptoms. And there's, thank goodness, a plethora of tools now available.
And I want to get into that because I want to hear you describe every single one of them
Yes.
so that I can offer that kind of treatment and send them to you, my patients, or learn how to do it myself if time permits, which I doubt, but all right. But beyond that, and it's absolutely true, I have absolutely similar cases, and there's very little help out there. I think there are companies like Hims and Hers and others that have tried to fill a gap just for privacy, but I don't think they can drill down into the targeted, necessary, customized approach. And so you're still at a loss because you don't really know the direction to go in. And then there are the 60% of women who have vaginal atrophy. So where do we go from there? Because it's that area. Now, we generally, just to keep it kind of simple, we generally start with application of local estrogen and testosterone sometimes, but not necessarily at the vagina, usually in other places, like where there are fewer terminal hairs, sort of behind the knee as a cream, or in the antecubital fossa, like in the elbow. There are other places to apply it. I know there's some doctors that believe you should apply it to the labial folds.
Right.
Sometimes that helps. Some women feel that difference. There are pellets that I know you also use. So beyond that, though, what can women seek out? How would you recommend a woman begin to sort out the steps she might need to take?
Well, each person's an individual, so it does take into account how much time they have, how private they have to be. So that would entail, is there downtime with the procedure? So if there's downtime, they may not want to do that treatment like a laser. There's a 3-day no penetrating intercourse downtime. Yet with radio frequency, if you use unipolar or monopolar, you don't need to have any downtime. Nobody has to know you did anything.
The downtime with the laser, I can't imagine that we couldn't say something's going on in like a urinary tract infection, which is common with atrophy, vaginal atrophy. And use that as like, no, for 3 days, we'll meet up again in 4 to 5 days, unless it's a really hot relationship and you need to be on top of it.
Literally.
Yeah, exactly. And so I can't imagine, it sounds like it's really a cure in a lot of ways. And you can get women up and running in the way they want to.
And one other factor is all of our women with breast cancer. 1 in 8 women we know in a lifetime will have breast cancer in this country. And very often they're just too afraid, or their oncologist is telling them no hormone therapy.
Yes.
And under those circumstances, it breaks my heart to think that they feel less feminine because of the alteration of their breast anatomy, to then encounter the terrible discomforts that maybe tamoxifen or the aromatase inhibitors cause to their vaginal tissue.
Yeah, in fact, I had a similar experience years ago where I started a protocol at Yale and use it to this day, where we give those women who are suffering testosterone, and then we can block it with aromatase inhibitors so they don't make estrogen.
Yes.
But even in this day and age, some OBGYNs and other doctors think that even local hormone would be hazardous to women's health, and yet it's not true. It doesn't extend beyond the local area.
That's right.
So it makes me sad as well. So I'm delighted to hear that there are approaches that can overcome it, because I see a fair number of women like that.
Yes.
Good.
So being able to use a laser, there's CO2 or erbium lasers on the market for vaginal tissue, and they do involve penetrating the vagina and rotating the device. in a circumferential fashion, and then it's going to cause a micro injury in the wall of the vagina, and the body's response to that, much like having Fraxel to the face,
Right, or laser
the
to
cosmetic type of thing, they altered the same exact laser to be able to be used painlessly in the vagina.
Is this the Femi lift?
The Femi lift, yes, is the CO2
But you
that
do the procedure, or is it?
Yes.
So in terms of rotating it, it's something
Yes.
that needs to be done with precision.
Yes.
Okay, got it.
Indeed.
And
yeah.
then do you need to back it up with hormonal treatment as well?
No.
You don't need it at all?
No.
And it's you need to repeat it after a certain
one a month for 3 visits, and then once a year is the average. Sometimes women will begin to get a little bit dry again, maybe at 8-9 months, feeling some vaginal discomfort. They could come back at that point, no harm done, and get their maintenance. So I have patients coming some women say, I love it every 6 months, and that's fine.
Well, that's great. I want to turn to the MFEM as well. What is it? MFEM 360?
NFAM 360 is radio frequency.
Okay.
The beauty of this device is that understanding radio frequency as an energy, what we must do is get the tissue to a 40 degree to 42 degrees Celsius and maintain it there for 2 to 4 minutes at a time. Each treatment must get that to that level. And being able to determine if the tissue is actually at that therapeutic level is a little tricky. So the company that created MFEM 360, BTL, did come out with a method that on the screen and on the handle of the device, I can tell the temperature of the tissue every second I'm using it, which is amazing. And the probe comes in 2 different sizes in diameter, and an energy comes out in a 360 degree pattern. When radio frequency first came to the market for the vagina, we didn't have the ability to see how warm the tissue was getting, and it looked kind of like the head of a toothbrush and would go in and out of the vagina literally for 30 minutes. I can't get a lover to stay in there that long. It was just a little weird to me.
Right.
So I've never used that device.
So I used radio frequency in the past through my sister's practice because she's a derm.
Okay.
And it was so painful, like for the neck and for tightening.
That's correct.
Yeah, but
It's
it isn't
not.
painful? Okay.
No.
So there are ways to block the pain, or
Yeah.
you don't have pain?
No pain.
Oh, okay. Fantastic.
and
so
I-
that's with MFEM 360.
Yes.
When you're using radio frequency.
That's right.
What would make you
Intravaginal.
choose the
One versus the other.
versus the other? Yeah.
Yeah. The reason to choose between a laser and radio frequency, a few aspects. They're almost equal in efficacy. Lasers are the gold standard no matter what we do. They are stronger, so they usually work a little bit more efficiently. But there are a few reasons. Number one, radio frequency is delegatable in most states. So if we are not there and the patient needs a procedure, our PA or our nurse practitioner could do the procedure. The other is that the radio frequency can be done as close as once a week versus all the way up to a distance of once a month. Whereas the laser, you would not repeat that closely. So the patient must wait a whole month and come back.
And then they have
Once
3
a-
days offline.
That's right. And the other is the downtime.
Right.
So for all those reasons, you may choose one over the
it.
other.
Fabulous. It's great.
Yes.
And then we're turning to Almo Duo.
Yes.
What can you tell us about that?
Well, Alma Duo, low intensity extracorporeal shockwave therapy, has been used in men for many, many years, extremely effectively for erectile dysfunction all over the world except for the US. Alma brought Duo for men in January of 2021. And they already had 7 clinical trials documenting efficacy. What's beautiful about the Duo, number one, it's painless. There's no need for numbing. Whereas other extracorporeal shockwave therapy, which is called radial devices, you need to numb the penis. And once a penis is numb, it will be numb for 5 hours. Men don't like that.
I can imagine.
They do not like that. They freak out around 4 hours and 55 minutes.
I remember being numb from the LP that I had when I gave birth to my second child, and my legs went numb.
Yes.
It was scary. Like, you don't know when you're going to feel it again. So I can imagine the penis, which is very vital to men, not being happy about it.
That's correct.
I think the men in the audience are not going to be wincing when they hear this.
And 6 times they have to go back.
Oh my God.
And the device has to be moved constantly because it's that snappy, even with numbing. So those devices, and they're nowhere near
That's worse than a mammogram for women.
Yes, and they're not as efficacious because the energy protrudes in an outward cone, and it's only at a depth of about 1.5 centimeters. So when Duo came to market, painless, no need to numb, and can penetrate, doesn't need to move either, because the energy goes with an inner cone at a depth of 13.5 centimeters.
Wow. Yeah.
Unbelievable. So it hit the market running in the United States, and any gentleman that comes to my office and has it is just thrilled with the results.
This is applicable both for inability to get erections, spontaneous erections, erections, and maintaining an erection.
That's correct.
Excellent.
So, and difficulty in orgasming, reaching orgasm, so delayed ejaculation and even premature ejaculation. It helps all those parameters by regenerating blood flow to the area, which then helps with innervation. So it's a secondary effect on the nerves in the penis as well.
It's fantastic.
So
because
it's fabulous.
We can absolutely address libido and erectile function, but not in as an effective way as this sounds. And also, over time, men notice a decline in ejaculate and a delayed ejaculation that can be nerve-wracking for them and their partner.
Exactly.
And so being able to address it from all angles sounds amazing, incredible.
And pun intended. So the way we apply it is all angles. We apply it penetrating into the pelvic floor and along the penile shaft. So the company came to me and said, "Do you think this could work in women?" And I said, "If it hurts, we're out." So number one, I got to feel it. So when I first felt the device, I laughed. I went, "How could this do anything?"
You didn't hardly feel anything.
Nothing. It's loud, but it's like a gentle tap. No discomfort whatsoever. So I did the first clinical trial. First time it had been used for women. And I had 20 women in the study aged 21 to 65. So it wasn't a gigantic sample. It was just a pilot
nice
study.
Broad spectrum.
But yes. And the interesting outcome was that I had no idea what was going to happen. So they said, "What are we going to feel, Doc?" And I'm like, "I don't know. We're in this together. Here we go." And
not unusual for clinical research.
Right? We had no idea.
As long as the risk benefit, and it didn't sound like there was any risk, and it could be all benefit or at worst neutral.
That's exactly right. And the very first symptom that every single woman in the study had was better lubrication.
Fantastic. That's great.
Isn't that incredible?
That's like incredible, yeah.
Blew my mind.
Similar to men in that they need blood flow
right.
too, but we need it in a different way. We need it upon stimulation.
Exactly.
Yeah.
And then the secondary benefit was what we were looking for, which was better orgasm. So being able to have a better blood flow to her clitoral area improved her orgasmic function. One of my favorite stories there is a woman who's 54 in this study, and she worked from home. And I've developed an orgasmic scale as well, which has 5 little smiley faces. 0 is the dead. smiley face, and
Goes up from there.
and then the perfectly happy smiley face is a normally orgasmic woman, which is a woman who can orgasm within 5 to 10 minutes, and multiples are possible. Not a given, but possible.
Got it.
So she was somewhere in between. She was a 2 or a 3, and what that meant was she was unable to have an orgasm
Quickly?
no, it took her at least 15 minutes with a device.
Wow. Yeah.
On her own or with a partner. It was not happening otherwise. And when it did happen, it was like, that was nice. It wasn't swinging from the chandelier. So with the duo, she worked from home. She goes, Doc, I sit on my bed, Indian style, computer on my lap, and I never had a problem before. I never felt any desire. She goes, now I start feeling tingling. And she's like, I can't concentrate.
Nice problem to have.
Nice
I know,
problem to have. To go from not having much to
being able to, and learning to then contain it. We have the same issue with some men who, when they come in, say, oh, the sex life is fine, these are 50, 60, sometimes even 40. And I'll say, oh, so it's comparable to when you were 20. And they'll say, well, maybe not exactly. And then when we stimulate testosterone, 2-3 weeks later, they call up and, Doc, can you wind it back a little? It's a little too intense. I feel like I'm 18 again. So we get adapted to it. But if we can live like that, enjoy life to the fullest till 120, why not? And that's what we need.
That's what we need.
know. So painful sex. I know we talked about dyspareunia.
Yes.
All these devices would help with what we think of as dyspareunia and
Correct.
difficulty because it's uncomfortable. It's like that bristly
Correct.
hairbrush, or
Yes.
maybe even unable to get access. Penetration is hard.
That's correct. And let's say a patient is so uncomfortable that putting in a vaginal probe like the radio frequency and or the laser just is too uncomfortable to tolerate, even if we try to give them a little local estrogen for a few weeks. If they are still that uncomfortable, you can always use the Emsella for improvement in vaginal lubrication and blood flow. So the Emsella chair is high fem technology, high intensity focused electromagnetic energy. And this chair is in the doctor's office. It has a cone of energy that comes up and will make 100% of the muscle fibers in the pelvic floor contract.
It's like Kegels. But 20,000 Kegels in a half an hour instead of the few we
Correct.
can do. Yeah, we use it as well.
Yes.
And find great outcomes with incontinence.
Yes.
Particularly nocturial incontinence, where you're up multiple times at night and it feels like you have a
Exactly.
prostate.
Yes.
And so that's fascinating. And you've also applied it to men.
Yes, men, it's FDA approved for the treatment of urinary incontinence in men. Post-prostatectomy is an excellent place to begin to use it up to 6 to 8 weeks right after prostatectomy. A gentleman can come in and start regenerating the muscles in his pelvic floor that help not only with erection but also with continence, because a lot of men, once they have their prostate removed, leak.
Challenging.
Yes.
What about fecal incontinence? Because we have cases of that as well.
Exactly.
Have you found success with
Yes,
that?
absolutely. And it's all about placing the patient on the chair correctly. I call it the Emsella wiggle. They got to find the right spot where, where the energy is coming
Having done
up
it myself, you're absolutely
and
right.
hitting.
Yeah. It's amazing though, because having
Yes.
tried it, I slept through the night. And so
Yes.
you have to repeat it though. It's not something
Yes.
that lasts for years.
Not at
So,
all.
but it's
Nothing
great.
does.
We talked about achieving orgasm. It's
Yes.
great. Lack of a libido. Where do you find
Yes.
hormonally that is most effective, or do you have other tricks for libido?
Well, I will say that there's nothing like testosterone for a woman's libido. I do recommend that the most because libido means desire and mostly affecting the psychological side. However, indirectly, all of the devices that we've discussed today can help libido as well, because if we do see libido improve with any of these treatments, because if it doesn't hurt so much, she may be more willing and eager
not
to be
dreading it.
That's
Exactly. Yeah, we find the same thing, and you have the added bonus with testosterone, even
Yes.
just as a cream, sometimes as a pellet in some
Yes.
hands. We're now testing an oral version of testosterone that it helps with putting on muscle, because our
Yes.
testosterone starts falling in our 30s and we don't recover it. There's no way to recover it. So it's well before even perimenopause.
correct.
In men and women. We just have so little of it that when it disappears, and weight too, losing
Yes.
fat and putting on muscle. So, and building muscle when you do resistance training, preventing the glucagon-like peptide effect
right.
of loss of muscle as well.
So critical.
So I'm with
critical.
you there. Good.
Yes.
At least we're hitting it out of the ballpark there. I need to see these devices though firsthand. I really do. Can you talk a little bit about the plasma O-shot and the exomes and what you found there? Because that
Yes.
too is an amazing approach.
I asked all around what else is going on in this realm of sexual health, and I stumbled upon Dr. Charles Runnels down in Fairhope, Alabama, and he had invented the O-shot. And the O-shot, which also has a P-shot, so the O-shot is for women, the P-shot is for men, and what he uses is PRP, and PRP is a portion of our blood that helps us heal ourselves. It's platelet-rich plasma. So when we are little children and we scrape our knee, yellow goo comes out, scab forms, scab falls off, nice new pink skin, and no scars. We can't even count how many times we skinned our knees. So doctors who were trying to help athletes like A-Rod get back out on the field where the money is, they said, why is his scrapes healing, but his joints are not? What's going on with this yellow goo? And the yellow goo, when analyzed, we realized that it doesn't contain platelets. Platelets stop us from bleeding. We knew that. But the added surprise was that they burst open and release growth factors.
Yeah.
These growth factors act as little signals calling our stem cells and encouraging them to build whatever tissue is needed in that location. So I put PRP, pixie dust, magic, golden magic everywhere. It's in my face, it's in my breasts, it's in my vagina, and in the penises and my male patients, and I offer it obviously to all of my patients. These procedures are remarkable and incredibly regenerative.
And to just walk us through it, from what I understand, having had PRP myself, I actually did a little piece on it for Instagram.
Great.
Yeah, you get your own. It's your own blood, so
Yes.
it's autologous. So
Yes.
you're using your own natural healing agents internally. So it's
Yes.
physiologic. And you obtain that, and then you somehow get it concentrated down, and then use that purified concentration to reinsert in a person's
Correct.
the same
Wherever
individual.
they need it. Yes. So we use, we all do, otherwise it's not cool. But we do use FDA-approved kits that are specifically made for the isolation and concentration of these growth factors. So with PRP, we saw these incredible benefits. Joints healing better, the regenerative factors, the sexual benefits. And then we realized that perhaps stem cells. We're talking that PRP is a backdoor to stem cells.
It is.
Why can't we just go for the stem cells, which was the next logical process for physicians? And unfortunately, there were some cowboys out there. It got a little messy with the processing and the sterility and the appropriate management of stem cells. So the FDA kind of cracked down on the use of stem cells in the United States. And rightfully so. I'm not always a big fan, but in this case, I understand where they were coming from, although some places were doing it quite legitimately. But being said, the next step was what else? What's making stem cells tick? What makes PRP work? Well, we think it's exosomes. Exosomes are small vesicles that come off of our cells, all of our cells, So you can get it from our amniotic fluid that's normally discarded with a pregnancy. We can get it from placental tissue. We can get it from a person's own platelets. We can get it from a person's fat. And these exosomes carry what we call microRNA. And microRNA is like sending a letter from a cell to cell, telling the next cell what to do, encouraging it to either make a protein or not make a protein. And with those effects, we have incredible regenerative.
So it's like the DNA is creating RNA or ribonucleic acid,
Right.
and that ribonucleic acid is the message that says, this is what you need to do to get better.
Yes.
This is how you heal.
Yes.
So exomes are available as opposed to readily available stem cells?
Correct. So now in the United States, exosomes come from 4 different sources. They either come from plants, they come from amniotic fluid or fetal tissue. They come from a person's own, or they come from pooled platelets. And all of these different processes and sources are available for topical use only in the United States. So we can use them as skin products.
I'd love to hear more about the aesthetic treatments you offer, because I know you started with that as you segued
Yes.
from OBGYN to Botox
Yes.
to laser.
Yes.
So where are you with that today? What do you find useful?
Well, I do use all of these tools for the rest of the body as well. High Fem is a big part of my practice because I actually don't prescribe the GLP-1s because I do so much else. I can't do it right like you do with measuring body composition. I find that critical that if a patient is taking the GLP-1s, that they see a physician who's going to keep an eye on their body composition. Right. But I have a lot of patients who are on it who come to me and I want to maintain their muscle mass. So not only aesthetically, but functionally, sarcopenia being the #1 cause of nursing home admissions, I want to make sure our patients are maintaining muscle. So High Fem can be used everywhere on the body. M-Sculpt Neo with radio frequency and High Fem will build muscle and chisel the abdomen, the arms, and move it around the legs. And beautifully, there's a functional platform now that we can use for basically rehabbing injuries.
Before we wrap, I'd love to hear your thoughts if a close friend at a party or a stranger on a plane starts asking you what you do. What would you tell them, like the 1 or 2 things, both for maybe their general health, but also for specific sexual health, would be the best way to start?
What my typical go-to is about longevity. And the key is, first things that come to my mind is keep moving. That's #1.
Absolutely.
And never lose purpose. Have a reason to get up in the morning, even if it's to go take care of your grandchildren, even if it's just to tend to your garden. Make sure that in your life you continue to have purpose.
I love that, because I think of it as joie de vie. And if you start
Yes.
winding down, you don't have enough muscle, and depression and ability to function really disappears.
Yeah.
And from a sexual health point of view, would you point out one place to start?
Don't quit.
That's a great
Don't
line.
quit.
Right.
Don't give up. And I love the fact that there are answers now. And I've been on this soapbox for quite a number of years trying to get that word out. So I really appreciate you having me on today. So that
I love having you here. It's been
Thank
most
you.
fun, actually, and most out there. So we'll see. I hope they don't X-rate it, but if they do, so what? I think more people will watch. And finally, how can people find you? Like, what would be the best way to reach you online, in social, if you do any of that?
Yeah. Well, my website, everything is really simple. My website is drcarolyndelucia.com. My Instagram, where anyone can DM me, is Carolyn DeLucia MD. And I also have an ebook that they can download. And it's basically a glorified pamphlet on all of these
They'll love it.
procedures.
Well, I'm going to start with it, and we'll keep
Yeah.
it here accessible for our patients so they can learn about you and all the procedures you do.
Thank you.